Hello, everybody. Welcome. We're going to wait just a minute here while we let everybody load up before we get started. Hang in for, wait 1 or 2 more minutes until we've got everybody on board, and then we will go ahead and get started as close to on time as we can here. Okay, I think for the most part, it's looking like all the loading is done. So my name is Sue Chamberlain, and I want to welcome everybody to our webinar on healthcare compliance, the 2020 hot topics. We're very, very excited that we're going to be having Kelly here as an expert in compliance to really help present this for us. If you want to go ahead and go to the next slide. So this is so you can see what we look like. Kelly, just to introduce him, he's the Managing Director for CompliancePro Solutions. Kelly McLendon has been an HIM practitioner for over 40 years with specialization in electronic medical records, privacy, and security for as long as they've existed. In 2015, AHIMA awarded him their Innovator Triumph Award, among numerous other awards over the years. Kelly is a founder of CompliancePro Solutions, where he helped design and bring to market a software product called CompliancePro Health, which manages HIPAA and many other areas of compliance. He speaks about HIM, privacy, security, and legal records all over the United States and abroad. Recently in Abu Dhabi, UAE, and has authored countless HIM-oriented articles about and published a book about legal health records for AHIMA. So Kelly, thank you very much for participating in this webinar with us. I'd like to also take a moment to thank our sponsors. So our sponsors for this webinar include CompliancePro Solutions, which is an expert in compliance and also the software that we happen to use at RRS Medical. RRS Medical, which is an expert in secure PHI transfer, and Harmony Healthcare, which is an expert in human capital management. So we want to thank everybody for joining us and for our sponsors in this particular webinar.
Well, Sue, thank you very much and welcome everyone. We're so happy you could join us either today for the live session or in the future for the recorded session. We're going to talk about HIPAA hot topics and current information about all the new rules that are coming down. We're going to take a look at COVID and HIPAA, some 42 CFR Part 2, substance abuse, changes that have happened, some trends in privacy and security, the 21st Century Cures Act, interoperability and information blocking, a little bit on patient access rule changes. We thought that was fixed, but now it seems like it's maybe has some more issues, and then some enforcement. An interesting thing that about this presentation, when I present, typically make my slides extremely dense with information. The reason for that's twofold. One is so that I can remember to tell you everything during the presentation, but two, so you actually have a really good copy to go back from, because we cover so much ground. I give you enough information in the slides that you can decipher what we actually talked about and maybe use some of the references in there. This time, we're going to talk a lot about what has changed, what rules have changed, and what that does to our dynamic in the marketplace. We're not necessarily going to dive into all the details, because any single one of these areas could be an entire webinar on their own. So I'm going to give you some heads ups and things that you should be looking for and watching out for. There'll certainly be more information coming in the press. We'll probably do additional webinars in the future, but take this in as it comes at you in the fire hose and know there are more details to be had as you go forward. I love this quote. Of course, I'm a Bob Dylan fan, but seems like something he would certainly know a lot about. You learn privacy is something you can sell, but you can't buy it back. And, you know, once you agree to a privacy setting and put your personal information in it and it gets sold and goes into the marketplace, good luck getting it back. So it can be really quite an appropriate quote. COVID-19, OCR, and other guidance and waivers that have come down. I actually am on the listserv, any of you could be as well, for privacy and security from the Office for Civil Rights. They send quite a bit of guidance down through that listserv on a periodic basis. On some weeks, we'll get 2 and 3 different guidances in a week. What I typically do is take them in now during the COVID crisis, and I'll print them because I'm old and put them in a stack so I can get to them. I certainly electronically file them too. But that stack has grown to like 2 or 3 inches tall. So there's a lot of guidance that has come out from OCR and others. One thing to understand, HIPAA is not suspended during the pandemic. They put in place some enforcement waivers, or they basically have the judicious ability to decide what to enforce or not. But when disaster protocols are implemented in a site, HIPAA is relaxed on requirements to get patient agreement to speak to family members, ability to opt out of a facility directory, mandatory that you give them a notice of privacy practices, right to request restrictions, and right to request confidential communications. Those are waived flexibly. You're expected to follow them if you can, but in an emergency situation where you may not be able to, especially at the beginning of the pandemic when we were trying to find our footing, these were put into place. And a lot of them, the disaster protocols are still in place, so these waivers are still active. But again, it's not suspending HIPAA. They put in telehealth technical security guidance. There's been quite a bit of that. It's how to specify the HIPAA security rules for telehealth. You know, originally you could use Zoom and some of those without a lot of security controls. When we were really panicking and trying to get more bandwidth with telehealth, that's all tightening up now. So there's going to be fewer and fewer excuses not to be using a secured platform for telehealth. You can't be using unsecured forever. So now is the time to start securing your platform, and there's a lot of guidance from the government. There's been some cyber threats and malware that's happened, people trying to take advantage of the COVID crisis. They've got some VTC and Zoom hacking. Those are vendors that had happened. A lot of those holes now have been plugged, but be aware cyber threat and malware has increased of late. They have some discussions about restrictions on media disclosures, what you can and can't say, and guidance on the 42 CFR synchronization and the minimization of content requirement for substance abuse records. We're going to talk about that a little more in a further slide. And then civil rights. Office for Civil Rights also enforces civil rights. So they are very aware of and able to enforce. Maybe they had some ventilator triaging issues that ran up against some civil rights. OCR can look into things like that. So they've issued guidance on these, and they're not hard to look up from OCR. Also have enforcement discretion on some community-based testing sites, since a lot of those had to be stood up fast and were kind of temporary. Business associate public health oversight, meaning if you're a business associate and you're supposed to be reporting numbers for public health, there's times when there might be some enforcement discretion there, but by all means, they want you to report as much as you're supposed to report. First responders, and if they receive protected health information, if anybody you think violated your rights, there's guidance on that. They had a stakeholder teleconference about equal rights and other information. So you've got these all recorded by the Office for Civil Rights. And again, disparate impact on African American, other racial and ethnic minorities. There's a fact sheet on initiatives underway, and again, a link there that'll help you with those materials. Around the world, we've seen 60 plus US and other global data protection agencies, which could be governmental or not governmental. They've issued guidance and rules and standards, such as they are, about the pandemic. They looked at health data collection and management, COVID diagnosis, COVID reporting and data disclosure, work at home practices, and return to work practices. And I got this, see at the bottom of the page, from Fenwick and West article. I think it was a really good article. You certainly can look it up. We're not going to read everything here, but it is, because a couple more slides about this will come, but it is important to understand some countries are more restrictive than others, but here's a basic list of do's and don'ts. Things about data collection and prevention. Don't record taken temperatures, conduct workforce surveys of family health members, or request and obtain information about social interactions outside of work. And if some of these sound counterintuitive, look up the article and read it, because I think it's really pretty accurate. You know, do take non-recorded temperatures only when people are sent home to quarantine, then you record them. You know, conduct surveys asking if workforce members are having symptoms, require home quarantine, require a doctor's note. You can, in some locales, use cell phone tracking to track locations and of home quarantine, but that's dicey. You have to be careful with that. So as you look down this page, you see don'ts for disclosure of names and individuals, dues for disclosures made in limited circumstances. We've got, if you're returning back to the workplace, that you should follow CDC and EEOC and other data protection authorities' regulations and best practices. Again, you've got a list of testing dues, office strategy dues. Each of these is important to evaluate in the context of your own organization. But again, very good global list to try to keep you on track. Things with contact tracing, disaster recovery resumption, and remote working. All of those are, again, from this article that really are good for how do we get back to work, what can we do in the workplace, and it's a very complex subject. Workplace rules are a lot of times state law. Other times HIPAA gets in there as far as privacy and security is concerned. So we have to be very careful with resuming close to normal operations and changing operational patterns and things like that. Be sure you're carefully doing everything to keep within everyone's rights and to keep confidentiality as high as possible. We're a little bit worried about privacy liabilities following the crisis here. We don't know if Congress might give immunity for businesses for COVID-related reliabilities. I think that's something that the Republicans would like to see, but the Democrats would not like to see necessarily. So whether or not that ever becomes law to where, you know, that businesses are covered for COVID liabilities is very questionable, but something to keep your eye on. Liability and lawsuits for businesses or others related to COVID claims of being made sick, having unsafe employment conditions, those lawsuits are going to happen at some point. Class action lawsuits for privacy and security practices. For example, Zoom caused lawsuits when right after the pandemic happened, some folks were using Zoom with protected health information or something similar to protected health information, and they got Zoom bombed. It even has its own name now with somebody logging in. So there were class action lawsuits filed over those practices. There'll probably be more of those in the future. attorney generals haven't said much about litigation or liabilities following the outbreak. They've got more than that to deal with on their hands right now. But sometimes they've had regulations they could perhaps push back, such as California Consumer Protection Act, CCPA. But they did not. In California, they've decided to hammer down and go on with enforcement of CCPA, which just recently got the regulatory piece of implementation. So they're implementing CCPA. So COVID really isn't impacting CCPA implementation or enforcement. That's good to know for those in California or that do business with California customers. Certainly, COVID-19 has increased our dependence on technology, so expect more scrutiny of regulations for privacy and security. And be aware that there are quite a few different privacy-based rules in the United States, such as the Children's Online Privacy Protection Act and FERPA for student records. There are different rules that handle privacy and security that possibly some of them could be used for lawsuits later. Now, HIPAA cannot, and I don't know about these other rules, but we just want to say, be careful with liability. You want to follow as many of your regulations and rules as you can going forward, and you be very careful in your environments because there is a potential for increased litigation. We're not sure what directions it'll come from, but with COVID. We did get some important OCR guidance, and this has been out before about emergency preparedness and emergency situations. Some of this has been published with hurricanes in mind, but the concepts are the same as any public health disaster as well as natural disasters. So these are really good resources for emergency preparedness and emergency situations. Now, HHS and OCR issued guidance related to ransomware in December of 2019. They had a OCR cybersecurity newsletter for the fall. They had an article called "What Happened to My Data?" Update on preventing, mitigating, and responding to ransomware. Ransomware, as you know, usually comes in from a phishing attack, and then it locks up your computer system, and you have to pay to get it unlocked if they even will unlock it. That can be defeated by having good, appropriate backups in place and taking other security measures. They've given in-depth ransomware guidance with those strategies for prevention, mitigation, and recovery. And it's the usual suspects of things that they ask for all the time. Make sure you do a complete security risk analysis to understand where your vulnerabilities are and where your impacts would be if you got locked up. Your data, at least, getting locked up, maybe not you. Information security activity review. Are you reviewing the activity in your systems to understand where you have some automatic monitors? If there's some kind of large-scale exfiltration or improper actions, will you know it? Security awareness and training. Security training on cybersecurity, phishing, ransomware is very important to be happening now on a, I don't know, monthly, bi-monthly basis. You want to make sure that you talk to your employees about phishing, malware, ransomware, and that you record or write down what you spoke about and who heard it, and you keep those in your HIPAA files for 6 years. Security incident procedures. What do your folks do if they have an incident, and contingency planning? That's part of how do you, if you do get malware, what are you going to do about it? Can you go and use the backup from the day before? How do you know that's not corrupted? Things like that. Those are all statute numbers that came out of HIPAA that are there, but that's the guidance that's given by OCR typically, is to do these general things in the context of ransomware and malware. All right, switching subjects to 42 CFR Part 2, the confidentiality of substance use disorder patient records. We had a final rule. This is very confusing, so hold on tight. Had a final rule implemented with little fanfare in February of 2017. But then more and different rules came down with the CARES Act, which came down in March with the pandemic. And they just issued another final rule, July 15th, 2020, which implements 5 days ago. So we have to be very careful here. 42 CFR is substance abuse information. Typically, these are for federal providers of substance abuse treatment programs, but you have to be careful. You can have one provider providing those services in your organization, and then you have that kind of data, and you have to make sure that it is in fact covered by the SAMHSA rules as well as HIPAA. Now, what's happening in this final rule up here in red on July 15th and the CARES Act section 3221, they're synchronizing the 42 CFR with HIPAA. They're just moving past the discussion stage, which had been bogged down for years, and just basically saying this is almost the same as HIPAA information. You do have to be careful about segregating and understanding that you have this kind of information, but you no longer need a consent to disclose a specific detailed consent to disclose the information. You can use a more generalized consent like HIPAA does, or HIPAA's consent on the front end for disclosure of the substance abuse information. So be careful about that. It also clarifies the prohibition on redisclosure. You can now, to some extent, take SAMHSA or 42 CFR type information that's come into your records from another source and redisclose them for treatment purposes under certain circumstances. So be careful if you have 42 CFR data that you understand that these rules are changing. The CARES Act section 3221 said, here's some changes we're going to make. There'll be more coming within a year. Then we had the final rule on July 15th. Are more coming? When are they going to be here? I'm really not sure of that. But I do know much has changed, and the Section 3221, Protecting Jessica Grubb's Legacy Act, is important to understand. Again, the consent is only an affirmative initial consent is necessary for a covered entity or business associate or program subject to authorize disclosures for treatment, payment, and operations, just like HIPAA. That consent can be revoked, but you don't have to get a specific consent to release 42 CFR anymore. Single upfront consent can work. Redisclosures not prohibited. Defer to HIPAA rules. Public health disclosures are okay, especially if the identification under HIPAA is met. There's a change for a notice of privacy practices. But again, basically what we're doing is, or they're doing is, they're putting 42 CFR much more in synchronization with HIPAA so that we don't have an outlier law, which has been causing issues for years to be compliant with. Some trends in privacy and security for 2020. Privacy across the board is becoming more important. We're getting a lot more privacy laws now, especially at the state level, or at least they're talking about them. HIPAA's privacy hasn't really changed and it isn't projected to change very much, but other laws like California Consumer Protection Act, that's a privacy law in California. Other laws like that are rising now. So you have to watch for them because they don't necessarily supersede or get taken the place of HIPAA. So they have to work with HIPAA. Criminal cybersecurity activities, including ransomware and hacking, continue to be a huge problem. We are seeing better cybersecurity infrastructure in a lot of systems because there's been quite a bit of publications out by DHHS, Department of Health and Human Services, the Federal Trade Commission, trying to get even not just healthcare providers, but general businesses to up their game with their security. So while we've got a lot more threats, we do have some more protections and maybe some better compliance trying to combat these things. EHR dominance over paper records continues in the US, but paper, you know, while it continues to decline in usage, is nowhere dead. Many of our HIPAA violations are from your paper records, so be careful of that. Faxes, of course, lots of breaches or low probability of compromise incidents that aren't claimed to be breaches, but they're very close. That's the fax machine and hard copy records, so be careful with that still. We've seen covered entities continue to tighten, getting satisfactory assurances from their business associates, getting their business associates to tell them they are managing privacy and security compliance programs. But most business associates aren't asked about their compliance by most of their up-chain vendors or covered entities. So while we are seeing more covered entities and business associates asking their business associates about their compliance programs, certainly isn't universal yet. Should be, but it's not. We're getting an increasingly confusing mix of privacy rules. So when you look at this list of rules here, you know, how do they apply in a healthcare organization and what do you do? So CCPA, we know in a healthcare organization, HIPAA applies with privacy and security. But when do employee health records and COVID come into play? So you have an organization that has employee health records, employee gets COVID or gets tested or has their temperature taken, how and when can that information be used? Because that's not a part of your medical record. That's an employee health record that's actually governed by those laws. 42 CFR, we talked about that being complicated. FERPA, there are student medical records in the FERPA rule, so you have to be careful and cognizant of that. CCPA will apply even where HIPAA applies. So if you have a website where cookies are enabled and users log onto that website and you store personal information from that website, it's not really HIPAA that covers that because you're not making a medical record. You're storing selections and things like that from the website. That's covered by CCPA, so you're going to have to implement that as well. GDPR, General Data Protection Rule from the European Union. Probably not many of you will hear much about that. There is some limited applicability in the US, maybe for medical tourism. We're not 100% sure yet on that one. Washington, Nevada, many other states, privacy laws are probably coming, but probably not this year given the crisis. Anything in the wind about having a national privacy law so we don't have 50+ fragmented, disparate state laws? Not yet. So the rise of privacy, let's just quickly look at some of the new major privacy laws. Again, you've got the GDPR, the General Data Protection Rule. Really big rule, very onerous fines. British Air got fined 200 million, and others have been fined up tens of millions under there. However, the enforcement on those has been slowed down, so nobody's actually paid a fine under GDPR because of the COVID crisis yet, but that will certainly come back. So again, not a lot of experts in this area. I know something about it. I've actually built an assessment. I could do an incident workflow or a request from someone that requesting protection under the rule. So I know a little bit about that, but GDPR in general, complex, probably not a lot of US applicability, but it is absolutely interesting to understand because they give privacy rights. I think the right to be forgotten is one of their rights, so that doesn't really work in healthcare. We're not going to give the patients the ability to say, forget about my records, but in other types of businesses, it's important. So understand that the new privacy laws are not just for healthcare, but they're for larger groups of businesses outside of healthcare. They do include healthcare, but again, HIPAA is not going away or in otherwise being superseded too much by any of these new privacy laws. CCPA, again, very complex. It just started implementing this summer. They just finished the regulations on it. You basically are going to have to ask the people that log into a website, if you're going to collect their personal information, you're going to have to ask them what they can and can't do, what you can and can't do with that information, and you're going to have to follow their wishes. So having the privacy notices is a big deal under these laws like CCPA. And allowing consumers to opt out of having their information managed beyond its intended use. You can't sell it without telling them who you sold it to. Those are the kind of things that are happening in these new state laws and GDPR. In this article by Maurice Woodsher, the 2019 privacy legislation bomb cyclone, has really interesting details about how many new privacy laws are on the rise. 149 bills introduced, 14 enacted. All this is in 2019 before the crisis. What we have to do during the COVID crisis here is look at it from the perspective of this is going to come. It's simply been delayed in the short term. Now, the short term may be quite a while. We don't know the answer to that, but it certainly is going to delay this stuff for a while, but it's going to come. Left to its own devices without the pandemic, we would be knee-deep in new privacy laws to be dealing with. As it is, they're deferred for now. More on the rise of privacy. Gartner believes that privacy, as opposed to security, is going to be 10% of the market demand for security services in 2019, which could mean $114 billion worth of privacy services. And so it's a little bit of a gray area to say where is technology doing security or privacy. Data loss prevention is partially security, partially privacy. Identity governance and administration and identity and access management, they're shared by privacy and security, but there are areas shading towards privacy that are going to start getting more money and more attention because they're getting more important. There's more laws and regulations. And again, Gartner was reflecting that in their demand. I have no idea whether 10% is correct or not, who knows. But it is interesting to know that privacy is getting more money nowadays. Security has arisen, so they get a lot of budget, but privacy so far has gotten less, but again, that's changing. The NIST privacy framework. It's a framework. A framework's a model. It's like typically in a spreadsheet. It's a model of standards, best practices, some of which are mandated, some are encouraged, but it's really behaviors to safeguard privacy and security. So you're either got a word-based document with a table, or you have a spreadsheet typically, and they list in the framework the standards and what you're supposed to do and the references. I can build assessment templates from such frameworks. So I can take a framework like this and make an assessment template where you can ask yes and no questions and operationalize it. But the NIST privacy framework is good anyway. NIST is the National Institute of Standards and Technology. They've had a cybersecurity framework out for some time. They just, at the beginning of the year, excuse me, issued the privacy framework, and they're related to each other, but not exactly the same. They're still trying to get the initial pieces all in place for the privacy framework. They published and identified it, but they clearly say there's more work to be done. But again, the privacy framework starts to allow a business to look at their privacy environment and understand where they sit And that would be more globally across all of the regulations, but it is not in and of itself a formal assessment of your privacy. It's a set of standards that works towards allowing you to assess. I'm sensitive to those things because within my product, we have various assessment templates that we can use. And so I have to decide when we've got enough information on a subject to build an assessment template. I haven't built one for the privacy framework yet, but I believe that will come fairly soon. State laws, and you can see them here on the screen, have had quite a few iterations come down of the state laws, some of which have succeeded and many of which have failed. But these are the kind of laws that come back year after year until they get passed. So if not this year, and probably not a lot this year, but next year and the year after, we'll see a lot of these come into play. If you notice, it says CCPA copycat, CCPA-like. And so what you've got there is that they're using, these states are using the CCPA law in California to craft their state law. So some are definitely doing it that way and taking a hold of the philosophies of California, but many others are not. So it is not going to be as easy as learn CCPA and then apply it in the different state laws. Sometimes that'll work, sometimes not. The New York SHIELD Act is also kind of an interesting act. That is a security law that covers the metro New York area, and that means New Jersey and Connecticut as well, at least the ones adjacent to the city up there. It's not a real tough security law. It's written at a fairly high level. You have to identify potential insider threats, designate a security official, do a network risk assessment, implement measures to detect, prevent, and respond to system failures, have physical safeguards. So all of that's reasonably familiar security requirements that are not as tough as HIPAA. And in fact, HIPAA is if you follow HIPAA security and you're compliant with it, then you would be considered to be compliant with the New York SHIELD Act. So it's not so much that healthcare facilities also have to worry about New York SHIELD, as it's really a good example of some of the security laws that are going to be coming down in the states. I mean, this is a nightmare, but it's going to absolutely happen. You're going to have at least 50 state privacy laws, at least 50 state security laws. Sometimes you may have multiple security laws, such as California has some security laws, but they also have the Internet of Things law. So we're about to get this giant patchwork of laws and regulations to try and be compliant with. And now you're starting to see, perhaps why I said in the beginning, that a lot of this is letting you know what's out there, but how it all applies, we're still trying to figure that out. Information blocking. That's an interesting subject that we're going to talk a little bit more about. We've had the vendors earlier this year and late last year saying different things. You had Cerner vowing to open their electronic health records to third-party development so that they can work on the information blocking rule. Epic was kicking and screaming and resisting the Cures Act, information blocking and interoperability, but that's probably a futile effort. There was a study in March of 2017 saying that information blocking among EHR vendors is a routine act and they've limited interoperability. Well, no kidding. We've seen that out of the vendors for a long time. They also said hospitals and health systems are routinely blocking information flow. I have a little more problem with that from the HIM department because I'm an HIM person and I don't believe that we do a lot of information blocking from us, but that's my personal opinion. But this article seemed to think there was quite a bit of information blocking happening. So all of this relates to the Office of National Coordinator of Healthcare IT, or ONC's 21st Century Cures Act, interoperability and information blocking rules. So the interoperability means that basically EHR systems and other systems with patient data that are the designated record systems are going to end up having to have the ability to take information in from third parties and give information out to third parties automatically through the use of application programmer interfaces, or APIs. They're basically going to have to build interfaces. HL7 has built what's called a FHIR interface, a FHIR, which is probably the way to go. And they're basically saying you're going to have to, at the end of this year, your EHR is going to have to allow someone to log in and get this data set. It's a limited data set. It's called the US CDI, the United States Clinical Data Initiative. I've got it on one of the slides. But you're going to have to trade that data set information through these APIs in and out. So that's interoperability. And also, so that's something we have to be very, very, very cautious about. And we're relying on the vendors to provide the APIs to begin with, but how they work and what the workflow is and how can you check and make sure what is being done by the systems automatically is proper. There's all of that is up in the air right now. Basically, let's see, here's some terminology. Adoption of the United States core data for interoperability. That's a standard. So it was the common clinical data set, but now it's the US CDI. And that has several different types of data and documents. It's got personal information, summary information, diagnostic information. That's all a part of the US CDI. So if you have that data in an EHR record, that's going to have to be able to flow out through an API and possibly flow back in as well. So we have to be very careful. So it's not the entire record, but it's a major part of the record. Electronic health information export. Again, you're going to have to be able to export the information out of the system if it's a proper request. Information blocking is different than interoperability. Interoperability is allowing this data interchange to happen. Information blocking is preventing it from happening. So when you have had EHR vendors that would not give you a conversion routine when you change to another EHR, sorry, that's information blocking. That's illegal now. How they'll enforce it, I don't know, but that's probably a good thing. So there are, in fact, broad definitions of what information blocking is. There's these three clarifiers here, but to get to 7 exceptions for information blocking. You can block information to prevent harm, to promote privacy of electronic health information. And by the way, that EHI, electronic health information, that's a brand new term under the rules. They didn't call it PHI, protected health information, like HIPAA. They called it EHI, electronic health information, has a different definition than PHI, so something else for us to learn. To promote the security of EHI, so if you're promoting privacy or security of EHI, you can information block, but be careful because you could get complained about on that. You can recover costs reasonably incurred. Oh boy, they're giving us another fee model. Now we have a HIPAA fee, state record copy fee, and now maybe a fee for interoperability. Responding or information blocking, responding to requests that are infeasible, licensing of interoperability elements on reasonable and non-discriminatory terms. I hardly know what that means. And maintaining and improving healthcare IT performance. So you can't take your system down because you're trying to get a piece of information moved to another system. So these are your basically the exceptions to why you did not give someone the information they asked for. Typically, that's the patient or their personal representative. But that's information blocking, a whole nother layer on top of HIPAA that we have to deal with. Switching gears a little bit, we're getting fairly close to the end. The Department of Justice gave us some general compliance guidelines. I just thought they were absolutely great. You have to make sure your compliance program meets these 10 elements. Is it properly resourced? Do you have independent access to the board or the audit committee? Is compliance integrated with other functions? Have you used a risk-based approach to assessment? Implement metrics that matter. You've got to have different training for your gatekeepers and managers. You have to have third-party controls. You've got to communicate your policies and procedures internally and to third parties. You have to have a robust whistleblower process, and you have to evaluate the performance of your own compliance program. So those are 10 Department of Justice general compliance, not just HIPAA, guidelines, but they're great guidelines for your organization. Acceptable use of PHI by Amazon and Google. This came up a while back. Ascension, large healthcare system, wanted to have, I think, Google host all of their servers. People raised the question, wasn't that anti-HIPAA that they couldn't host the servers and have patient information all in the same, cloud? But that is actually not inappropriate access, and there wasn't anything with that. So if you're talking about moving platforms from one hosting environment to another, there are security questions, surely, but that's really not a privacy if the Ascension data can't be accessed by Google employees on a routine basis, and applications can be made that way. So that was an interesting little one that came up. I'm not going to talk too much about this. Sue may want to get into a little more of it, but we had the patient access guidance. There was a lawsuit from a large ROI vendor that OCR actually put up on their website that basically said if a patient directs you to send a copy to a third party, like a lawyer, you can charge the state record copy fees for that, because they're just trying to get around having to pay the state record copy fees. That's really, it was at the bottom line of it. We thought we had that solved, but now there's some trial lawyers that I've seen that are trying to say the 21st Century Cures Act renders that verdict basically moot. And now the lawyers are coming back trying to say they want their copies cheaper at the HIPAA rate because they think that they have to be provided under the 21st Century Cures Act and information blocking. We haven't formulated a good argument about that yet, but I will tell you that RRS is looking at it, as is HEOS, which is a group of ROI companies and other third parties that have an interest here trying to blunt or rebut the trial attorneys. So we thought we had solved that problem, but now looks like it might be opening up again in the future. So I am not going to go crazy with everything here, but don't let the attorneys bully you by saying the patient gave you the direct copy ability to have copies, and then charge the HIPAA record copy fee for that. Don't let the attorneys bully you on that. That's still not a solved problem. HIPAA enforcement, all of it's really important here is that they actually have started issuing fines for patient access and information blocking. They failed to give a mother timely access to her records, was an $85,000 fine. To the hospital, another one got an $85,000 fine and a 1-year corrective action plan because they wouldn't forward a patient's electronic records in an electronic format to a third party. And we continue to have things like OCR tries to get vendors to do the right thing, and the vendors then don't listen to them and then they get fined. But this is something to understand, that the director of the OCR, now he will change if the president is not reelected. If he is reelected, Roger Severino will probably stay in place. But anyway, he said, for too long, healthcare providers have slow-walked their duty to provide patients with their medical records out of a sleepy bureaucratic inertia. We hope to shift the imposition of corrective actions and settlements under our right of access initiative will finally wake up healthcare providers to their obligations under the law. So don't be a sleepy bureaucrat. Don't slow walk any requests for copies from the patients. I don't think any of you will. I certainly know that RRS won't, but there apparently are those out there that do. I'm not going to get too much into this one either, but we've had more enforcement over the last, we haven't had a lot in the last few months, but just before the pandemic, they were still issuing enforcement for all kinds of things, not having policies and procedures, not training your employees, not performing risk analysis on security, and they give out fines for that stuff. Here's another one. 2-year corrective action plan, $2.175 million fine, again, because they failed to do the right things under HIPAA, and the fines keep coming. So in conclusion, the future of privacy and security regulations seems to be tightening up because there was a wild marketplace, and we have a law and order administration that was trying to do a lot of enforcement. They didn't really advertise it, but we have seen the enforcement be a little higher prior to COVID. But again, things have changed under COVID, but let's be aware that's a temporary change. As for regulatory compliance, just keep what you're doing. Assume things haven't changed. Watch for your updates from the regulators and the press. It's important to be following that, either AHIMA, Engage, or some of these newsletters that come out from the web that you can see when regulations change. That's all good. Make sure you're always watching for arising security threats and vulnerabilities. Make sure you document in real time what you've done about them. Remember, the patient access issues still trying to be solved, and especially when they're directing copies sent to third parties. And realize that we'll be doing more subject matter. I'll do it with RRS, however we all want to go forward. But just watch, we'll have other webinars for you as we go forward. And I want to thank you very much for your attendance, and now ask, are there any questions?
Okay, so we do have one question that I saw come in. So again, if anybody has any other questions, just type it into the chat down below. Click on it and it will come up. But one question that came in is for confirmation regarding the changes in substance abuse patients. If a substance abuse patient authorizes their substance abuse treatment provider to send information to the family practice doctor, and the family practice doctor, their designated record set includes records from other providers, does the family practice physician need to do anything special to designate those substance abuse records any differently to keep from re-releasing or anything to that effect? Or is it okay to re-release in that situation?
It's generally okay to re-release. I don't actually have the rule at my fingertips to tell you if you have to couch it any differently, but general re-release is okay. There are a few exceptions to that listed, but in general, it's okay to re-release, and that's a huge change, as you know.
Yes. Okay, so I don't see any other right there, but to give people a minute to type, I do want to follow up, as Kelly said, AHIOS, which is the Association of Health Information Outsourcing Services. So it's where a lot of release of information vendors have come together, and they're You know, us competitors work together, but they're trying to deal with some of these attorneys. So we thought we got past the whole, it's a high-tech request, which there was no such thing. They kind of twisted that around to now what they're trying to do with the Cures Act. So just to confirm a few things for people, that it only applies, so the Cures Act is really only applying to electronic records, and they're being ones that are being accessed either through the EMR portal or through an app or that type of thing by patients. So this is not a new law for everything. There's a lot of parts to that. We also want to make sure that, again, that the Cures Act is even talking that they are entirely being deferential to the rules and fees permitted under HIPAA. And it does not restrict, in the law, does not restrict any allowable fees. They kind of picked and chose what elements they wanted to pick out of the law to try to make it say what they want it to say. So the other part I do want to bring out, there's a lot of confusion about the timelines for when the records need to be released. So when they need to be released through your EMR or through an app or that type of thing, so it's through your system to the patient, is different than your normal third-party request. So your normal third-party requests are still going to follow the normal HIPAA or your state law, whichever one's shorter. So that 10-day versus 30-day, that type of thing, okay? So again, ask questions with that as you need it. One more quick question that was brought up regarding post-COVID telehealth. My question is about providers, mainly physicians, getting a standardized disclaimer signed by a patient prior to a telehealth visit that includes language about medical advice being based on a patient's statements of conditions in lieu of a physical examination to avoid potential litigation. So do you have thoughts about that?
Well, that's not privacy or security, but certainly sounds like prudent behavior. I would be careful with that. Either when you get some advice off the internet from some attorneys, or you're going to ask your own attorney about it, because that's really starting to get into a consent for treatment and you're conditioning it. So be careful with that. But I don't know directly, that's not really privacy or security.
Yeah, and I would agree with that as well. You may want to talk to your attorney about that. One other question from Amy Savage from my past life. Does the CCPA or some new state privacy laws take precedence over HIPAA?
No, typically they're not. Typically they're going to be acting over different data sets. So, you know, and like with CCPA, HIPAA's been carved out. So there is no, you know, preeminence over either HIPAA or CCPA. But since CCPA covers different data than HIPAA, again, go back to the analogy of gathering data from website cookies or permissions that, you know, that are granted. You know, CCPA would apply, HIPAA would not apply. So yeah, there's no real superseding of one over the other, because in that case, they've said that HIPAA doesn't, you know, HIPAA information is not subject to CCPA.
Well, unfortunately, we are out of time. I want to thank everybody again. And if anybody has any additional questions, we will try to get those answered if any more do come in. Kelly, thank you. Thank you very much for all this pertinent information. Again, everything's kind of changing very quickly right now. So we will continue to probably work together to put more information out on this. So again, you're going to want to make sure to follow, I know at least RRS Medical on LinkedIn. I would assume Kelly also for CompliancePro or that type of thing, to be able to get the information of any updated education that might be available. And again, we look forward to providing more information in the future. Thank you again, everybody.
Thank you. Enjoyed it delivering to you.
Bye-bye.